Health Systems Transformation Team here at the Association of State and Territorial Health Officials. I'd like to welcome everyone to today's webinar entitled Leveraging Health System Transformation to Improve Population Health, Oregon's Experience. We're really pleased that we have Lillian Shirley and Lori Coiner on the webinar this afternoon with us to talk about the work that they've been doing with coordinated care organizations. And just last week, they issued a report to look at the first year of experience in Oregon that they've been leading. Lillian is the Public Health Director at the Oregon Health Authority, and Lori is the Director of Health Analytics at the Oregon Health Authority. Lillian has been a leader in Oregon's effort to transform the state's healthcare system. While she served as the local health director at the Multnomah County Health Department, she also led the governing board of the Health Share of Oregon and helped launch one of the first coordinated care organizations in that state. She also served as the vice chair of the Oregon Health Policy Board and has played a vital role in the state's movement towards a healthcare system that works better for Oregon. Lori oversees the quality and incentive metrics for Oregon's CCOs. CCOs are the foundation for the state's healthcare transformation effort for its Medicaid enrollees. Prior to this role, she served as the Director of Measurement and Reporting at the Oregon Healthcare Quality Corps. She is an accomplished biostatistician and was responsible for the development of the Quality Corps' quality and utilization reporting system and measure development. If you have a question during the webinar, please post it onto the chat box that you'll see at the lower left-hand corner of your screen at any time during the webinar. These questions will be answered during the Q&A at the end of today's presentations. We'll also have an opportunity for you to ask questions live, and we'll open up the phone lines during the Q&A sessions for those of you who are interested in asking additional questions. At the end of the webinar, you'll be directed to an evaluation survey, so please take a few minutes to help us by completing the survey, because any feedback that you offer will help inform future ASTHO webinars. So I'll now turn over the webinar to Lillian Shirley. Thank you, Lillian.
Good morning, and thank you, Monica, and I want to thank ASTHO for giving us this opportunity here in Oregon to share our experience with colleagues around the country, and as we move forward together in this important work to transform population health. So the first thing I want to just talk about a little bit is Oregon's recent history, to put it into a context that this is a journey we've been on for a while, and in 2009 we passed a bill in our legislature that consolidated our healthcare purchasing into one agency, which includes Medicaid, public health, and the Public Employees Benefit Board as well. So that would be all the employees and retirees of the public sector system. In 2011, House Bill 3650 created a framework for a Medicaid coordinated care organization. And the Oregon Health Policy Board developed the vehicle for the implementation of that change. And here we call coordinated care organizations. In 2012, Senate Bill 1580 approved the implementation proposal, and we applied for and were approved from the feds to get an 1115 waiver, and I will talk about what was in that. And then our CCO, Coordinated Care Organization, procurement, certification, and Medicaid member enrollment began. So here we are in 2014. So what are the requirements of the waiver that we received? And these bullets talk about those requirements. This is what we have to report on. There are 6 very specific areas. And the biggest risk is to reduce the annual percent increase in the cost of care by 2 percentage points. Plus ensure that health and quality care improves and that is tracked simultaneously. And establish a 1% withhold for timely and accurate reporting of data. Establish a quality pool. Establish a primary care provider loan repayment program. And train at least 300 traditional health workers to drive a change in the actual model of care of delivery. So our SIM Model Testing Award was a 45-month, $45 million award to spread this idea and help support health system transformation and their implementation. We received $4 million in the Public Health Division to specifically enhance population health surveillance efforts, which included a Medicaid BRFIS study on race ethnic oversample and our Oregon Healthy Teen Survey, to further develop and enhance a web-based public health assessment tool, and to support local public health authorities and CCOs to implement evidence-based population health practices. And I'll talk specifically around the 3 areas that the Public Health Division was responsible for. Oregon's coordinated care model is built on these 5 building blocks and these are represented in the legislation and also part of what we submitted to the feds to get the waiver. So we are going to integrate and coordinate care, which includes making sure that we have high penetration of medical homes, that we have a global budget with a fixed rate of growth that ties back to that 2 percentage points that we said that we would make sure that we held costs to. And our metrics with incentives are actually the area that we're looking at for quality, accountability, and flexibility, telling local communities and CCOs, we're not telling them the what of how to achieve these elements, but we're telling them the what and not the how. They can go about it with their own assets and local conditions, but we're telling them what it is they need to do. And then local accountability and governance, and I will talk about the community advisory councils. The global budget, the global budget also includes mental health funding, physical health funding, and dental health funding. And that was staged in different parts. The last group to come in was the dental piece of it. The 16 CCOs really give coverage for the vast majority of Medicaid members in our state. They also, that global budget grows at a fixed rate again, and they're responsible for health outcomes. And the withhold that you heard me reference from the waiver is that that pays as a performance payment for the 17 quality measures. And the other element is that you are required to have agreement with local public health authorities. This is a service area map for Oregon. You can see that the 16 CCOs cover the entire state. And in eastern Oregon, if you look up to that orange color, you'll see that that's a vast amount of rural and frontier areas where there is one CCO that is working with the counties in that area. And we'll talk a little bit about how we're incentivizing that collaborative work through our SIM grant. So each CCO is required to have a community health council, advisory council, and this is in the legislation. It must be at least 51% consumer membership. And we took this guidance really from the success of the federally qualified health center movement that has a consumer board of at least 51% membership. The seat for a community advisory council member, there must be one person that moves on to the corporate board of the CCO, whether or not it's a not-for-profit or a for-profit CCO, and responsible for overseeing the development of the community health assessment as well as the community health improvement plan. So each CCO in developing these are required to work with local public health and other partners to develop a community health assessment. And by other partners, we also refer to our equity coalitions and in these areas, and the nonprofit hospitals as well. So our key levers are, whoops, I think I skipped a slide here. The organization for our public health oversight with the SIM grant and integrated into healthcare transformation on the state level is that I am the public health director, and I serve on the executive leadership team with the Medicaid director, the Oregon Health Authority director, the mental health director, and the director of policy and research. The policy officer in the public health director's office serves on a cross-agency systems transformation initiative team. And again, someone else sitting in my office, the health system transformation lead, also serves to connect our public health division programs with the other health authority programs, local public health authorities, as well as the transformation center initiatives for this specific work. Our key levers, we believe, are these 4 elements. This is the levers that will help us achieve the data and metrics, primary care transformation, again, medical home, medical model changes, workforce development, and our community health assessments and improvements. Our goal with data and metrics is timely access to data on the health status of the population, as well as how the CCOs are doing individually, and Laurie will be talking about that. In terms of primary care, the population health perspective through these complex healthcare needs, community and clinic linkages, as well, again, one of the secret sauce, I think, is patient-centered primary care homes. And for workforce development, these are the elements that we've included in our work. And the supporting the public health system around policy systems and environmental change and communications was a specific strategy, knowing that locally and at the state level, public health is very strong on programmatic work, but needs some capacity building in these areas. So the role of the SIM-funded prevention grant programs, these frameworks that we're using, you can see they are not, they're not something that isn't known across public health practice and work, but I think that the emphasis that the community setting as well as the health system setting have to have an integration and an agreement for what evidence-based strategies in their particular community. So these are our SIMS grants across the state. We did a competitive rollout, and as you can see from the pictures, it's very different, very rural, very frontier, as well as the major population center. The developmental screening in the rural area, preconception health, tobacco in the Mid-Valley, and in the Multnomah County, Clackamas, and Washington County area, working on opioid overdose. These priorities came specifically from their community health assessments and the community health improvement plan. The Community Health Improvement Plan implementation, our role at the state is to support the local communities in this work. And our specific work here as we revisit our State Health Improvement Plan is to make sure that they're aligned both with the Community Health Improvement Plans for local government, the CCOs, as well as on the local level, they're doing a really good job of including and coordinating with the IRS required hospital community health improvement plans and assessments. Our Medicaid Tobacco Cessation Initiative is one example. We modeled it after our work in Massachusetts. It's cross-agency, and these goals are for the Office of Equity and Inclusion, within the Health Authority, mental health, the Transformation Center, and Medicaid as well. Some of our early lessons learned is communicate, communicate, communicate. We need to align with our state's strategic vision. We have a lot of political support in the governor's vision for doing this work and for doing it across state agencies and across different sectors. we recognize the amount of change that's going on in the healthcare delivery system, and we always ask first, are our solutions to help actually rooted in where they are in their journey? Because we know that change is a process and it's happening all the time. We're constantly trying to get more upstream. We refer to transformation as that early work that I showed you earlier with the legislation that we passed was Transformation 1.0. 2.0 was setting up the CCOs and rolling them out. We think we're in 3.0 now, and we in public health are designing our strategic planning processes and our internal work to look at 4.0, Health System 4.0, when we will be ready for much more of a collective impact around what are the goals that we want community by community, region by region, to create a healthy Oregon. So I'm going to stop there and turn it back to Monica, and thank you for this opportunity.
Thank you so much, Lillian. We're going to transition now to Lori's slides, and just want to remind people, please continue to send us some of the questions in the chat box. We've already got a couple queued up, and so I'll hand back to Lori.
Good morning. Can everyone hear me? Monica, I just want to make sure that the speaker transferred successfully. Good morning. Thank you to ASTHO for having us, as Lillian said, and I'm going to pick up where Lillian left off and give a brief background on the metrics and our accountability, both the Coordinated Care Organization accountability to the health authority as well as the health authority's accountability to the federal government. I'll provide some summary of the CCO overall performance and then also provide some specific metrics highlights. The full report on our first year of health system transformation was released last Tuesday, and it's available on our website, and I'll provide that at the end for anyone who'd like to investigate further. So just to give some background, as I mentioned, there's multiple accountabilities that are built into the health system transformation approach. And so we being my office, the Office of Health Analytics, reports on 33 measures annually. Well, actually we report them on a quarterly basis to the CMS, or the Center for Medicare and Medicaid Services. And the purpose of these 33 measures is to ensure that quality and access don't grade during the time that we're trying to hold costs down by 2%. And if after 2 years, if we do not start to show improvement, then there are some financial penalties to the state if these goals are not achieved. We will be performing our first test of quality and access and providing that information to CMS in January of 2015. However, we've been tracking it, so far we are meeting our goals. And then separately, the CCOs, or the Coordinated Care Organizations, are held accountable to the state on 17 measures. And annually we look at whether those 17 measures for each CCO, whether they met the performance improvement target or the benchmark, and determine how much of a quality pool or these incentive funds that are paid out. In this first year, we compared 2011 as a baseline, that's before the CCOs were in existence, to experience that occurred in 2013. We began to report to CCOs their data on a monthly basis in September of 2013. We included not only their performance metrics, but also lifted the hood, as it were, so that they could see who the specific members that were included in each of the members, and we spent lots of time in validation with the CCOs in this first round so that they really understood where they stood in terms of the metrics and that we had the methodology for computing the metrics down in a way that everyone agreed on. The other point that I want to take a little time to mention is that the 17 metrics were established through a metrics and scoring committee, which was a public committee process. The committee was established through the state legislature, and that committee continues to assess the measures and make recommendations on an annual basis. So in our July meeting, for example, we'll be reviewing progress on all the 17 measures, and at that time there's an opportunity to drop a measure if we have exemplary performance on it, or modify benchmarks as needed to continue to see improvements. For 2014, the baseline will move to 2013 experience so that the CCOs are required to improve every year. Lillian mentioned a quality pool, and what that is the dollars that are held for CCOs to reward on improving performance, as opposed to payments for services and the numbers and types of services. So this is our first move towards paying for outcomes rather than a fee-for-service type model. The quality pool for 2013 was 2% of the actual CCO paid amounts. It was $47 million, and CCOs need to either meet a benchmark or an improvement target. Each of the 17 measures is on a pass-fail basis, with the exception of the measure on patient-centered primary care home enrollment, and that was a sliding scale. So in order to earn their full quality pool payment, CCOs had to meet the benchmark on at least 12 of the measures, and then, as I mentioned, that PCPCH, or patient-centered primary care home measure, they needed to have at least 60% of their members enrolled in a PCPCH. We distribute all the dollars every year, and so for those CCOs that don't meet 100% of their quality pool, that money is left on the table, as it were, and it goes into what we call the challenge pool. The Metrics and Scoring Committee selected 4 measures that they felt were the most transformative, and so the challenge pool is paid based on just depression screening, diabetes, blood sugar control, screening for alcohol and drug misuse, and patient-centered primary care home enrollment. So the report that we released last week provides a summary of how the CCOs did on the metrics, and I'm going to show you that in the next slide. Again, we compared 2011 to 2013, and the report also has, for almost all the measures, race and ethnicity breakouts, comparing 2011 and 2013, and I'll show you a few of those as well. And then there are some utilization and financial measures at the end of the report. This is the link, www.oregon.gov, if you'd like to take a look at the report, and also lots of details about our metrics and metric specifications and such. So this shows for this first year, there are 15 CCOs. Pacific Source now is split for 2014, will be splitting into 2. But we had 11 of the 15 CCOs received 100% of their quality pool payment, and then there were 4 that met most but not all. We were very pleased with this initial distribution, because those that didn't meet all of the metrics met 10 or more, and so we felt like there was really huge progress in just 1 year of work. This is the final payment distribution. You'll see that each of the CCOs, or many of them, received a little bit more than the first round, and that's due to the challenge pool payments. And so those CCOs that met 100% in the first distribution then got some extra money in many cases from the challenge pool. So where did we see these improvements? We saw large improvements in emergency department visit reduction. Overall, statewide, we reduced by 17%, and we reduced costs for emergency department by 19%. And I'll show some specific data in a moment. We saw decreases in hospitalizations for chronic conditions. We saw very big increases in developmental screening. And again, as Lillian mentioned, really a key component of health system transformation is primary care home enrollment for patients and building that coordinated care model within patient-centered primary care homes. We also saw big improvements in electronic health record adoption and a large reduction in early elective deliveries. The early elective deliveries are the result of the hospitals having a hard stop on them and CCOs working in their communities to make that happen. The early elective deliveries went from about 10% in 2011 down around 3% in 2013. We had mixed results and lots of progress on a number of the measures. You'll see we showed how many CCOs met targets. We had very few CCOs meet or exceed benchmarks on most of the measures, and that was by design. The benchmarks are really established as goals with the idea that we would meet them in 5 to 10 years. And so in some cases we had improvements over benchmark, but for the most part the CCOs met their improvement targets. If they continue to meet those improvement targets across time, then they will exceed the benchmarks, as I said, within 5 to 10 years. Here's some examples of data. We decreased emergency department visits. This is a rate per, I think, 1,000 member months. And so we went from 61 in 2011 down to 50.5. We're approaching the benchmark. Just to pause about the benchmarks. In most cases, if there is a national benchmark, especially national Medicaid benchmark, we selected the 75th percentile, or in many cases the 90th percentile, with the idea that the CCOs in Oregon would be performing at the 90th percentile for the nation. And for some measures, there isn't a national benchmark, and then the Metrics and Scoring Committee had staff do research and selected those. Here's an example of the decreases in emergency department visits by race and ethnicity. The way that you read this is the gray shaded dots are the 2011 rate. The blue dots are the 2013 rate, and the red line is the benchmark. And in this case, we'd like to see the emergency department visit rates go down, and in most cases that happened. In some it remained very close, as you can see for Hispanic, Latino, and Asian American, though they are below the benchmark. So we saw progress across all race and ethnicity categories. And then in the report for each measure, we also show the specific CCO results, and again saw decreases in emergency department use across all the CCOs, and with 4 of them now, or 3 of them now, below the benchmark. As I mentioned, we saw decreases in hospitalizations for chronic conditions. Here's an example of congestive heart failure. And this measure is important because if patients with congestive heart failure are well managed, particularly in places like a patient-centered primary care home, then they can remain out of the hospital and reduce costs and have better health for the patient. We saw similar results for COPD, and also for adult asthma. we did not see decreases in hospitalizations for short-term diabetes issues, and so we'll be looking at that data more carefully in the, across the next few months. An area where we saw market improvement is in developmental screening. This is developmental screening for children up to age 36 months. And we haven't reached the benchmark, but saw large progress in 1 year. And again, we saw this improvement for at least some improvement for all race and ethnicity categories, as well as most of the CCOs. The two that are down in the lower right corner of your screen, you'll see how an arrow points down. That means that their rate, for example, Cascade went from 60.1 down to 58. However, that's well above the benchmark. We had 2 CCOs surpass the benchmark in just 1 year. Just a little side note, we have spent a fair amount of time, and there isn't unfortunately time in this talk to go through it, but for those, we're looking at those CCOs that had large improvements and working with the SIM-funded Transformation Center then to help learn what they did and spread those best practices to other CCOs. And that's a partnership with the Transformation Center. We had very large increases in member enrollment in patient-centered primary care homes. The goal is to have all members enrolled in a Tier 3, which is the kind of highest performing patient-centered primary care homes. At this point, nearly 79% of the members are of the CCO members are enrolled in a patient-centered primary care home. This is important. We believe Medicaid expansions happening now in 2014. The data I'm showing you does not include that expansion, but we're hopeful that by having the CCOs reach out to newly enrolled members and have them enrolled in a patient-centered primary care home can continue to keep our emergency department rates down and start members on coordinated care right away. This is an example of how the CCOs improved in patient-centered primary care home enrollment. You'll see Eastern Oregon, as Lillian mentioned, it's a frontier area. It's very sparsely populated with a lot of small practices, and they worked very hard with their primary care practices to get them certified as a primary care homes, and went from about 4% of their members enrolled to 63%. And we saw for other CCOs those huge gains. Again, the focus is on learning what they did and how they did it so that we can share best practice. So the CCOs didn't perform as well on a few of the measures, and in this case the measure is called SPIRT. That stands for Screening, Brief Intervention, and Referral to Treatment. It's a process by which members are screened once a year at a primary care home visit for risky alcohol or drug use. And then if they're found to have risky behaviors, someone in the practice conducts a brief intervention. Statewide, at the beginning, essentially the rate was 0. This is a new practice, and so we saw an improvement up to 2%. We saw one CCO that went to 8.7% screening, and I guess I'll pause here because it doesn't sound, you'll see the benchmark's 13%, and what we're measuring here is the secondary screen. So it's not the initial couple questions, but if a member says that they drink or use drugs, then they go through a larger, more structured screening process, and that's the 13% benchmark. But this is an area where we have lots of work that still needs to be done. We do have what we call an SPIRT work group, and that's stakeholders including primary care practices, some of the CCO medical directors, and analysts that are working to figure out better ways to both capture data and change workflows in the clinic setting to make this happen. Another area that we will be talking to CCOs over the course of the next few months and to learn about is access to care. This is through the CAP survey, so it's a patient-reported measure. And what you don't see in this slide is that what you do see is that some of the CCOs increased and improved over benchmark, some decreased, and some stayed relatively the same. But if we look at it by children versus adults, we saw that more of the adults have difficulty with access. And then also we are watching this and want to learn from those CCOs that improved access with the big influx of newly enrolled members that we're seeing with the Medicaid expansion. So next steps, we will continue to report at the state and CCO level. We are building some new dashboards that will be delivered to CCOs on a monthly basis. So we'll continue our monthly reports to them. We also are reporting to CMS on a quarterly basis, and we'll continue our full public reports like the one that went out last week. We'll be rolling in the 2014 data. Our next report will be later in this year, and we'll be able to look at how the metrics have changed with the expansion population. We've in December, we were at about 600,000 Medicaid members or CCO members, and we've increased since January by almost 350,000 new Medicaid members. So it's a large increase. We'll be providing the CCOs in August with their calendar year data by race and ethnicity. So what we provided in the report is just at the state level, but we'll be providing CCOs their own. We're working with the Office of Equity and Inclusion on a learning collaborative with medical directors in August, and they will continue to work with their communities to talk more fully about differences that are seen by race and ethnicity. And then we also will be providing analyses of additional subpopulations, including by language and by disability status. So for those of you that would like to look more closely at the report, we do report on all of the 33 metrics. Here is the link, and I want to thank everyone for listening to my talk.
Thanks very much, Lori, for going through those slides for us, and appreciate all the questions that are coming into our chat box. We have a good amount of time to try to get through some of the questions that were posted onto the chat box. And so before I get to that, operator, will you please remind participants about how to line up for the live Q&A?
Certainly. And if you wish to register for a question over the phone, please press star, then the number 1 on your telephone keypad. Again, that's star 1 to register for any audio questions.
While folks are queuing up for live Q&A, I'll go into the chat box questions, and I think either Lori or Lillian can answer these. They're not directed to either of you specifically. The first question is whether you can give us some examples of the CHA's outcomes, the community health assessment outcomes. A related follow-up on that one is, are CCOs required to invest into communities or just, quote, take into consideration as it's required under the IRS CHNA rules?
I'm sorry, could you repeat that? I can't find it on the chat box, Monica.
Oh, I'm going to read them for you. So the specific examples of the community health assessment outcomes and whether they're required to invest into communities or just take into consideration as it's under the IRS CHNA rules.
Okay, I'll give it a stab, and Laura, you can jump in. The requirement is not specific what they do with that. There's another one I saw when Laurie was talking about one of the CCOs receive their payment and how are they going to decide around that. I think the mechanism that we've used here in the legislation is the global budget, because that incentivizes community investment as well as it incentivizes working beyond the specific population barriers and the specific clinical barriers. So I'll just give one quick example. One of the CCOs had a high rate of smoking in pregnant women and also a high rate of obesity in pregnant women who were winding up with C-sections, and the babies were going to the NICU. Understanding that just clinical interventions around these issues do not necessarily create sustainable change, they actually are paying on a contract of the local public health department in their region to work on the kind of public health interventions that we know that work around environment and policies. So that's one example. There are others, but we can talk about it offline if people would like to get in touch with us. The other thing I think in the question, who makes the decision, and I'll answer another one too. How did we recruit CCOs? CCOs were not recruited. They are new entities. The state said that all of the Medicaid patients are going to be assigned to this new model, and then the CCOs came out of organizing themselves in different areas of the state. So some of them became kind of new entities that came out of Medicaid managed care plans or other types of insurers, and expanded the board as required by the legislation to have a local authority on it. The one that I'm most familiar with in the metro area actually has someone from housing, someone from alcohol and drugs, the mental health authorities, as well as all of the hospitals are represented, and all of the payers, almost all of the payers in the region. So that board will decide how to reinvest the dollars. But in many cases, you have community-based organizations that sit on the board itself, but are definitely involved in the community advisory councils.
Operator, do we have any questions? Do we have any callers on the line for questions?
And no, there are none at this time.
Okay. I'll ask another question to both of the presenters. Can you please tell us a little bit more about how specifically the state and local health departments are engaging with the patient-centered medical homes that have been established?
Laura, do you want me to take this too?
You can. I can also chime in.
Okay. Well, why don't I've been talking too much. Laura, you start. Okay.
So the patient-centered medical homes are, at least through the metrics, are engaged with local health departments because in order to improve, we have a measure on making sure that children who enter the foster care system receive a mental and physical health assessment within 60 days. And so one area that there's been big focus on is working with the local public health field offices that that are handling the children's change to foster care, and then hooking them up with their primary care provider and mental health provider to get those assessments. So that would be an example. There's a number of other cases where, because the CCOs now are responsible for both mental health and physical health, where there's needs to coordinate with the local public health and county public health agencies to make that effectively happen. Finally, there is an example of a CCO that was the county mental health agency was performing home visits for children that were higher risk children and conducting developmental screenings. And so they were linking with the CCO and the primary care providers to get that information that was obtained for the developmental screening to a child's pediatrician so that they could start to organize services and care. So those are some specific examples, and I don't know, Lillian, if you have some more.
Yeah, I think one of the traditional areas for public health is home visiting, maternal child health home visiting through targeted case management, which supports a lot of that for Medicaid clients. And that money will be going into the CCO's global budget within the next 6 months. And the CCOs, executive directors, and medical directors have sat down with local public health to talk about exactly what that would mean and how do we make sure that it isn't, that these services are expanded in a way that allows the local public health authority to visit and work with not just the CCO's membership, but, the broader community. I think those are some of the examples.
Thank you. Operator, any callers on the line?
And there are none at this time.
We've gotten a couple questions about metrics, and was just wondering, I know we could probably go to the report, but just curious if you could give us some examples of the behavioral health and dental services measures that you're using.
So the integration of behavioral and physical health measures include, the one I mentioned, children who come into the foster care system if they have a physical and mental health assessment within 60 days. Another is the screening for alcohol and drug misuse. A third is follow-up after hospitalization for mental illness. Members need to have a follow-up within 7 days after being discharged. And then another is follow-up for children who are prescribed ADHD medication. So those are some examples of the behavioral health measures.
Okay. I'll just keep going through the chat box. Can you tell us more about how the quality improvement organizations are involved with the CCOs, the QIOs in your state?
I'm not sure. We have a couple. They sit on these committees, like the metrics and scoring committees and the quality committee. But I'm not familiar with the context that the question is coming from. Laurie, is this sparking anything?
If you're talking about the state QIOs, ours continues to monitor one of the performance improvement projects and do some validation with CCOs, but they are working in more of a compliance function than real quality improvement at this time. So, and I don't know if it helps, Monica, but there are a couple specific questions on metrics that I think might be helpful for me to answer. So I'm going to dive right in if that's okay.
Sure.
So somebody asked about that Health Share of Oregon was awarded nearly $14 million as an incentive award, and asked how the decisions are made within the CCOs to determine how these awards are distributed among partner agencies. I wanted to say a couple things. First off, the incentive payments that the CCOs receive are based on how they perform on the quality metrics, and then it's weighted by the number of members that they have enrolled. So Health Share of Oregon is the largest CCO, and then their quality pool amount is larger, and it's based on the enrollment. The CCOs are required to report to the health authority annually on how much of the funds are distributed back to providers, and we have heard that there are quite a number of the CCOs now who are working on alternative payment methodology to incentivize providers to work on the metrics and improvements in care overall. So we haven't received the specific reports, but we have in asking and learning about what they're doing to move quality forward, we do know that a number of the CCOs are paying differently. Also, somebody asked whether the CCOs report on 17 of the 33 metrics and whether they get to pick their measures. So the 17 incentive metrics are part of the 33. The CCOs provide us some information directly, but mostly the state, my office, calculates those metrics, and the CCOs do not pick them, but the Metrics and Scoring Committee establish those metrics. So I just wanted to cover some of those details around metrics, and now I'll turn it back over to you, Monica.
There's a question about whether or how the CCOs, if the CCOs bear financial responsibility of costs that don't meet the 2% versus the projection threshold.
Yes, they are required to live within their global budget, and for those CCOs that did not receive all of their incentive payments, for example, then they hold that risk. So, and I don't know if you want to add anything, Lillian, but
no, it's a one sentence. Yes, they are responsible. Which is part of forcing the conversations around who else needs to be at the table, whether it's a community-based organization or a local public health authority, to achieve the goals, because we're trying to drive community accountability.
There's a question about the workforce development area, and you referenced developing a loan repayment program under that bullet. Can you expand more on that work?
No. We can get back to you on the specifics. It's just in the developmental stages, particularly for new, what I would call new professions.
I can elaborate a little bit. The Office of Equity and Inclusion has been involved in working on expanding the role of traditional health workers, and that would be part of the workforce development piece. And so, they're working to promote the use and the ability to pay community health workers or traditional health workers as part of the CCO. And so that, as Lillian said, it's underway and new, but it is moving forward, particularly with the focus from the Office of Equity and Inclusion.
Thank you for that additional context for that particular question. I actually do think that that's a topic that a lot of the callers and other members would be interested in hearing more about. And just a reminder, we will be posting the Q&A online along with this webinar and copies of the slides. Our operator, one last chance for any live questions out there.
And you have a question from the line of Robert Sewell.
Madam, that was my question on workforce. Anything regarding the loan repayment program would also be of interest. Thank you. So
the Oregon legislature did establish a program within the state. It's called Scholars for a Healthy Oregon. That does rather than loan repayment, it actually pays tuition for physician assistants, dentists, medical students, and I think nursing as well. And the payment is made for tuition, and then the students have to agree to work in a rural part of Oregon for each year that they had their tuition paid. And that program is underway and being part of the health authority is administering it. In terms of additional loan payment programs, though, I would have to look to find out what else there is.
There's a couple of questions about gender distribution, and so I'll go ahead and ask this, and I'm not sure if it's so I'll go ahead and ask it as it reads. And the question is, what is the gender percentage distribution for the respective organizations?
I can answer that, sort of. So the CCOs in 2013 were, more heavily weighted with women and definitely children. And the 17 incentive metrics reflect that. There's a focus on child health, maternal and child health. We have been, I didn't provide it in the slides, but when we look at the new enrollees for the Medicaid expansion, the proportion of men being enrolled is increasing. And so it's something that we're going to be thinking about because the distribution is for males is increasing on the adult side. So more to come on that.
Okay. Thanks. Two more questions I'm going to try to squeeze in. How are participants enrolled with a CCO? Are they placed within a CCO, or do they have an option to select which one they want to enroll with?
Lillian, do you want me to take this one?
Oh, yeah, sure. I was,
okay.
You would keep going.
I feel like I'm talking too much. The members are allowed to choose. In many cases, if they live in an area where there's just coverage for one CCO, and unless they're willing to travel, they don't have as much choice. There are areas of the state, both the Portland metro area and then the southern part of the state, where there are multiple CCOs, and then the members can select.
Can I just add a little bit to that? But I think, remember, the CCO is just the organizational structure, and the participant who, chooses a CCO, or if they're in an area that doesn't have it, they very often get to choose the provider or the provider system within that CCO that they wish to remain with or to begin with. So you might get assigned to a CCO and then you want to go to, trying to think here, like the Richmond Center of Oregon Health Sciences University, or you may want to choose to be in one of the Providence clinics or stay with a clinic that you've been in. So that we try to have as much patient choice as is feasible within the, the constraints of capacity.
Thank you, Lillian and Lori. Unfortunately, we're at the top of the hour, so we'll need to wrap up this webinar and the Q&A sessions. We will be taking all of the questions that we weren't able to answer and following up with Lillian and Lori to get responses to those questions that we weren't able to cover on this afternoon's webinar. So I want to thank everyone again for joining us today. As we mentioned at the beginning of the call, you'll be immediately directed to an evaluation at the end of the webinar. Please take a few minutes to complete the survey. I'd also like to thank Lillian and Lori for presenting on the webinar today, and also thank the CDC for sponsoring this afternoon's webinar. A recording of all the slides and Q&A will be available on our website within a few days. The web address is on your screen now. We hope that you'll use this webinar as a resource and share the link with others once it's available. Thank you, everyone.
Thank you very much.
Many thanks.